really running out of time. So, do you have any final comments you'd like to make on the issue? How can we make that paradigm shift?
Yeah, if I could come in here, I think one of the things that we've done very well is to define things. We've defined, for example, what should be the outcomes. We've defined what should be the standard of care prophylaxis. I think the next paradigm shift is for us to take care of the 75% that have no access. Instead of putting them onto episodic treatment, is to move directly into prophylaxis. Now, the only way to do it is not to move to 8 or 9 or 15 units per capita, is to start with a low dose. In other words, you tell my country that it's okay not to treat episodically, but if you start on a low dose, you're already jumping across. To me, that would be the paradigm shift.
That's the long-acting landline to cell phone shift.
Exactly. To me, that would be actually a very, very important paradigm shift, because then that takes care of the baseline and you're closing the gap.
In fact, I would go even one step farther. I would say it is probably unethical for any regulator ever to require an on-demand study arm again. The science is absolutely clear that prophylaxis is the way to go. And so now we should be talking about a phased entry of prophylaxis to make it affordable as our new paradigm. On-demand episodic study arms should be a thing of the past.
I think it's completely embarrassing, just to emphasize what Mark said. When you see a slide of a clinical trial, and the on-demand arm has an annual bleed rate
30
of 40,
bleeds a year,
and everybody else is talking about 1 or 2 or 4 and arguing whether 2 is better than 4, but they're still having this on-demand arm at a bleed rate of 40. Mark is absolutely right. That should be declared by the community as unethical.
It should be criminal. I mean,
well,
no patient should be asked to go. Well,
criminal.
no patient should be asked to go through that. It's unnecessary.
I think as well that Jerry talked about the need for differential pricing. That's not going to happen very quickly, but I think there's a possibility. You look at an analogy. There's a new hepatitis C drug from Gilead, sofosbuvir. It's $84,000 for 12 weeks treatment in the US, 67,000 euros in France, 900 euros in Egypt for the full course of treatment. They have already decided on differential pricing. So why can't we go back to the concept of looking at agreed twin-track pricing for some countries with products in the next couple of years?
Alfonso?
And I think that, well, to be really provocative, where a long-acting product might really make a difference is where you don't have all the facilities that you have here, and where having vein access is more complicated, and where you have to drive 100 kilometers to get to the closest treatment center, and being treated with 2 infusions per month might really make a difference. And that might also be transformational. And I would say that while we look at making this drug available here, we should have them stepping 2 steps, not only one, not only skipping the on-demand, but skipping the standard treatment with standard half-life product. And that might be something that I would like to see some of the company to support in a country or in a couple of countries to show that that makes a difference. And that might be something that have the community buying in.
Could I just put in a plug? Because we've been spending a lot of time talking about the cost of drugs as the cost of care. But really, if we want to maximize the value of these new drugs, we need to also be working on the governments to invest in the care systems themselves and the treatment centers. These are going to require a lot more personalized time to get the treatments right for the right patients, and governments are feeling pressure all across the board. And if we scrimp on those costs, we're going to lose the opportunity to really maximize the value of this new generation of drugs. So it does require investments on multiple fronts, but a small increase in supporting the care system actually will dramatically improve the value of the new drugs when they arrive.
Well, I think everybody can agree on that last point. So I think we'll call it quits there. And I want to thank you all for being part of this panel.
Thank you.
Thank you.
Thank you.